Good morning, everybody. Dr. Vasquez here, coming to you live. And I'm only going to be coming to you live for about another hour because in about exactly an hour, I need to leave for a group exercise class so I can get my ass kicked in ways that I wouldn't do by independent will. So, topic right now is we're going to talk about two articles that I've read recently, which I think are quite excellent. And you know how I am about positive news. I love to share it. So we're going to look at an article that was just published, I believe out of Italy.
Why'd you read so much? Why'd you read so much?
But how? Well, my brother has his sword, and I have my mind, and a mind needs books like a sword needs a whetstone. That's why I read so much, and a mind needs books like a sword needs a whetstone. That's why I read so much.
In a international specialty journal, not necessarily the best journal in the world, but it's a pretty damn good journal. I've followed this journal for, I don't even know, 15 years, 20 years, something like that. It's a good journal. And occasionally they provide their articles for free, and that was the case with one of their recent multi-center Italian primary research articles, which again was really excellent. And it does help to clarify a few clinical questions that some of us have had, especially in the world of inflammatory diseases and autoimmunity. So I have talked about this particular disease, this specific disease. I've talked about it in your favorite textbook, Inflammation Mastery, 4th edition. And you can see I've got a few pages bookmarked because I talked about it several times in this book. So for the 1% of 1% who have actually read this book cover to cover, which is probably nobody basically, you can still find the topic that I'm going to discuss. It's in the index. So I will talk about this disease. I will talk about one of the patients I had with this disease, who's mentioned in the book specifically, one of many patients. And we're going to talk about a couple different things. So I'm going to start writing a few notes and organize a few ideas and explain why I think this is such a good article to discuss. So I'll just say topics, obviously. We're going to talk about the diagnosis. We're going to talk about the differential diagnosis. So diagnosis we abbreviate typically as DX, differential diagnosis as DDX. Then we could say treatment, which is TX. But we could also say management. So like I said, very insightfully, in this book, because I used to have to teach orthopedics and rheumatology, and I had to teach students how to manage those patients, not just treat the disease. So one of the things that a medical student or a healthcare student or a chiropractic student or a naturopathic student should learn at some point, conceptually, is that treatment is not the same as management. And I think that this particular disease allows us to, just about any disease would give us this opportunity, but this particular disease, in these particular cases that I'm going to discuss based on this research and based on the cases that I published here in the book, this particular disease does give us the chance to look at a clinical problem or conundrum from both perspectives. How do you treat this and how do you manage it? Those are two different questions. So I'm going to talk about those. So we've got the diagnosis, the differential diagnosis, the treatment, and like I said here, management. So how I would treat this condition is very straightforward. If you've read the book, you already know the answer. Well, let me say it slightly differently. If you've read the book and you've watched some of the videos I've published recently, especially the one on NF-kappa B, I think you would understand how to treat this condition immediately. Like I don't want to say well, I guess I could say it. The treatment of this condition, if it's uncomplicated, is kind of a no-brainer. And you could use what I have already published here, because I do talk about treatment and I do talk about management. And I don't recall, and I think that I probably didn't talk about steroid therapy in the book. I may have mentioned it a little bit. I'm a little more familiar with it now just because I've had another 10 years of clinical experience. And I've started using anti-inflammatory steroids more so now than I used to in the past. I don't know why that is. I guess maybe because I treat more complicated conditions these days. Maybe that's why. But not as if they weren't complicated enough previously. But anyway, I would probably be more inclined to talk about the use of steroids in this condition at this point. And I may not have mentioned it very much in the book. So let's see. So we're going to go through, oh, here's the other thing. We're going to go through diagnosis, differential diagnosis, treatment management. But in order to do any of that, you have to actually understand the disease. So interestingly enough, in the new article, which I'm actually quite happy with, and I don't really have a bunch of criticisms, within the scope of the article, they did a good job. They said they were going to talk about this, and they talked about this, and they did a good job talking about this. They didn't talk about anything outside of that. And in my opinion, for the sake of completeness, from a pathologic and diagnostic standpoint, I think they should have talked about like the disease pathogenesis. So I'm going to talk about the pathology of this particular disease, and I'll show you a picture of it. Probably by this point in the video, I've already put up one of the images, which is certainly not diagnostic, but it is suggestive of the disease. And that's why we have to talk about differential diagnosis in this conversation, because even with a classic presentation, it's not an exclusive presentation. So if a patient presents with this particular disease, like let's say someone in their family was sick, and then this particular patient also got sick, and then they came into your office with joint pain and a skin rash, you could start to think that it's the disease that I'm going to talk about today. You could start to think that. But you wouldn't necessarily think it's only that, or you wouldn't necessarily think, wow, this is black and white, this is easy, it's super clear what the disease is, I don't have to entertain other diagnoses. You got to entertain a lot of other lab tests, because this could be other things. So just because someone comes into your office with joint pain and a skin rash, basically good luck, you got to figure that out, so the error in talking about this disease would be to present it as if it's obvious, because it's not obvious. Somebody comes into your office with joint pain and a skin rash, you're starting from nothing. You got a few DDXs, some of which are benign and are going to solve themselves within about a week, and you don't have to do anything. Others are the same disease, but maybe a little more aggressive, and you want to do some steroids or something like that. If you want to treat this from the way that I've discussed it in the book, then you could do that too. And you could easily do all of that together. You could do your differential diagnosis, you could come to a reasonable clinical assessment, you could put them on some steroids, and you could do the protocol that I've mentioned in the book. I believe it's chapter 4, to be specific. So you can do all of that, but you have to understand kind of where you are in terms of your ability as a clinician. So like I said in my video from last week, if you're a chiropractor like I was, if you're practicing in Texas under a chiropractic license, trying to do naturopathic medicine, which is what I did for 6 years, and you've got the Texas Medical Board like watching every move that you make, that's a social situation and a professional situation that also determines how you're going to manage this patient, right? So again, if this were 20 years ago or 25 years ago, and I was practicing under my chiropractic license in Texas, trying to do naturopathic medicine, and young and naive and inexperienced and but very well read, which means I kind of figured I kind of knew what I was doing. And of course, everybody thinks they know what they're doing until they get older, and then they look back and they say, wow, what the hell was I doing? So, again, like I said earlier in today's video, things that I perhaps wrongly assumed, 25 years ago, or things that I would do differently now based on another, 25 or 10 years of different experiences. Those help provide me a perspective on kind of how to do things right, or how to do things more right. So the way that I would have managed this 25 years ago is actually very similar to how I would manage it now, but not exactly the same. So I would do things differently, perhaps obviously based on more experience. Again, I provided the example of kind of the social context. A chiropractor practicing in Texas, managing this condition, better be careful, right? And it's not, the issue isn't necessarily more or less training or whatever. The issue is you have to consider the political and social climate that you exist in. So, and it applies to other specialties as well. You know, if you're a young family medicine doctor, you may have never seen this condition. And you could run the risk of not managing it appropriately. And so, you know, the issue isn't, oh, well, you know, chiropractic here and family medicine here and whatever. The issue isn't necessarily that comparison. Because like I said, a person could go through medical school having never heard of this condition. A person could go through family medicine residency having never seen this condition. And so then they graduate from medical school, from 3 years of family medicine internship and residency, and they've never seen this. So they may have enough clinical experience and kind of savvy to kind of figure it out and say, whoa, this is over my pay grade, you know? And that would be the appropriate management strategy. So that's why, again, we'll talk about management in just a moment. And I want to be sure to tell you something that I learned. I learned this from Alan Gavey, and he learned it from one of his medical mentors, and I want to be sure to tell you something, because that one phrase forms kind of a conceptual basis for how to manage tricky patients like the ones that we're about to discuss. And again, I'm going to try to get through all this in an hour because I do have to leave for an exercise class pretty soon. So, and that's good. I mean, this is a really great topic. It's great information, but I don't know that it necessarily needs more than an hour. So I'll try to get it done in an hour. So again, I'm going to show you some pictures of what the clinical presentation looks like. So the clinical presentation is joint pain, nothing really to see. You would palpate the joints, you would inspect the joints, and you wouldn't really find much. Maybe a little puffiness, maybe a little pain. You can find that in anybody, even people who don't really have it. So that's very non-specific, and certainly isn't diagnostic of anything. So a patient comes in with a couple of tender joints. You would have to differentiate that from acute monoarthritis, which I discussed in chapter 1, because you have to know how to manage, if you're a clinician, you have to know how to manage acute monoarthritis. So again, and that's a pass and fail core competency. You have to know what you're dealing with. You have to know what the differential diagnosis is and what the potential complications are. So I'm going to write that down. So along with the quote that I am getting to about from Alan Gavey about differential diagnosis and management, it's a really great quote, and that's why I want to make sure I include it. So I realize I'm being very abstract. I'm kind of giving you the template and kind of the conceptual outline. Most of what I've just said you could apply to any disease. You have to know the pathology. That's why I talk about pathology in every section of my book. Then I go to diagnosis. I talk about differential diagnosis, and then I talk about treatment. So that's exactly the outline of most chapters in the book where I talk about clinical conditions. You have to understand the disease. You have to know how to diagnose it. You have to know what conditions look like that same disease so you don't get screwed up going down the wrong rabbit hole. You have to know how to treat it. And like I said in chapter 1, and I've said it for 25 years since I taught rheumatology and orthopedics, you have to know the difference between treatment and management. You may have a great treatment plan and you might mismanage the patient and you could still be in trouble. So, having said all that, and with the interest of getting this done in less than an hour, let's see if I'm ready to dive into this. I think I am. So, yeah, let's see. So pathology, I could talk about that right now. Differential diagnosis. I do talk about this quite a bit in the book. So if you've read the book, like actually read it, not just buy it and then look stuff up in the index. But if you've actually read the book to get the, continuum of thought development, then some of what I'm saying is going to be redundant because you already read the book. But if you haven't read the book, then this is going to be kind of a focused conversation on this condition. So let's just get into it. The condition that I'm talking about right now is parvovirus B19 induced arthritis and vasculitis. And so that's the title of this particular article. Again, great multi-center study that came out of Italy, I believe. And what they did here is they clinically assessed and followed, at least for short term, they followed some patients who had acute parvovirus B19 induced arthritis. A lot of controversy for 25 years since I taught rheumatology back at Bastyr in 2001. A lot of controversy has existed around this topic, but I think this article helps to clarify the fact that we don't need to have controversy. Now we have good data based on this article and based on, 20, 30, 50 years of research. So the controversy has been whether or not parvovirus B19 can cause arthritis, and the answer now is very clearly yes. So the topic is parvovirus B19, I've got space, vasculitis, and arthritis. Arguably, you could say arthralgia, because it's not truly a joint inflammation. It's just a little inflamed. It's mostly painful. If you want to call it arthralgia, which means joint pain, or you want to call it arthritis, which means joint inflammation, you could kind of go either way. So what they didn't talk about in this article is what connects vasculitis with arthritis. And if you've read my book, and hopefully I was clear enough in the book, I may not have been because that wasn't really the focus, but hopefully I was. We'll look at the sections in the book where I talk about this. So we'll find out if I described it well or not. But again, back when I wrote this book, and for the past 30 years or so, we really didn't have clarity as we do now, thanks to this article. So, I can't fault myself for not including this article in the book because it was just published last week. So the question I would have for you is, what is the pathogenesis of the vasculitis and arthritis in parvovirus B19 rheumatic disease? So again, patient comes in with joint pain and a rash. What's the rash? The rash is from vasculitis. And you can see that in the pictures from this particular article. They show some really classic and perfect pictures of a vasculitic rash on the pretibial area, which is the area in front of the lower leg, the tibia. And that is a classic location for vasculitis secondary to parvovirus B19. But guess what? It's also a classic area for vasculitis for a bunch of other conditions. So again, as I said before, that would be the classic presentation, would be somebody who had a sick family member, or they had a mild respiratory infection maybe last week or so. They come into your office. Now they've got a vasculitic rash either in their hands and feet or pretibial, and they got some joint pain. What are you going to do about it? Well, you could certainly entertain the diagnosis of parvovirus B19, but you're not off the hook yet just because you read that article and you think that's what it is. It could be a lot of other diseases. It could be a drug reaction. It could be early autoimmunity. It could be a catastrophic autoimmune disease that's about to blossom and you're only seeing it on the first day and you don't know, but next week your patient's going to be dead. But they came into your office, and let's say here's the other thing. You also have to think about, like I said before, you have to think about your social context, but some of that also includes timing, like time of the week. And obviously, again, your location and your training and all that. So if you are a family medicine doctor, a new family medicine doctor, and you're the only doc in town, and you're an hour away from a big regional hospital, and it's a Friday night, and you get this patient, you may have a different way of managing this patient than if you see them in the middle of Houston, Texas, or Dallas, Texas, or Miami, any big city with a big medical center, and it's a Monday morning. So the obvious thing is, as I just mentioned when I was kind of giving you the case presentation, this is not a static clinical presentation. So when you're dealing with clinical conditions, one of the things you can think about, or I would say you probably should think about, is, are you looking at something static? Or are you looking at something dynamic? Static, is it old? The patient's had this condition for 25 years or 20 years or 2 years? Or is it new? So if this patient comes into your office with joint pain and a skin rash, and they say, I've had this condition for 5 years, I've been diagnosed by a rheumatologist with having whatever disease, and it's Monday morning or it's Friday afternoon, it doesn't really matter. You know you're looking at a stable condition that's being managed and being supervised by a specialist. You're off the hook. You don't have to worry over the weekend. That used to be one of my rules when I was early in clinical practice. One of the rules that I wisely developed was, am I going to worry about this over the weekend? If the answer is, because a lot of patients, they know they've got something going on, they put it off all week, they come in on a Friday afternoon, and then all hell breaks loose. So, in my experience, clinical practice, cash-only practice, Houston, Texas, if somebody made an appointment on a Friday morning for a Friday afternoon, I knew it was probably going to be a problem. The worst cases are the ones, again, who put it off to the last minute. They're trying to get a weekend pass. So they want to come in on a Friday afternoon. They want you to say, hey, everything looks fine, and they want to go home because they want to get the reassurance that everything's okay. So they kind of hedge their bets, so to speak, or they kind of stack the deck in such a way as to facilitate you saying, it's fine, don't worry about it. Because they know it's the weekend, they know that everyone's ready to, quit thinking about work. But, like I said, in my experience, those were some of the trickiest and most difficult patients. We're talking about like life-threatening blood clots, life-threatening like autoimmune complications and things like that. It was always a Friday afternoon. So again, I realize I'm going around a bit, but that's how clinical practice is. You get one patient, and then you get another, and you have to be able to bounce from topic to topic and kind of put everything in a context. Again, if you're a new family medicine doctor and this patient comes into your office on a Monday morning, you've got time to figure this out because you have time to watch the evolution of the disease. If you're a new family medicine doctor in a small town and the nearest medical center is at least an hour away, and you've got an uneducated, or let's say unsophisticated patient who isn't really good at kind of managing their life because you've taken a little bit of social history and you find out they're alcoholic or they just got out of rehab for whatever, or they're irresponsible, your management of a patient like this would change depending on who you are, where you are, what day of the week it is, how bad you think it is, how responsible your patient is. And if you have any other data like, oh yeah, they were diagnosed with multiple sclerosis, or they've got diabetes, or they're morbidly obese, or they have an ejection fraction of 30, or whatever. All of that's going to shade how you evaluate and manage your patient based on what you think is going on. So anyway, patient comes in, you're looking at this and you're saying, hey, you've got painful joints. Okay, well, that's arthralgia. Hey, your joints are a little puffy. Okay, that's arthritis. Hey, it's only 3 or 5 joints. That's oligoarthritis, not necessarily polyarthritis. And I'm looking at this rash on your pretibial lower leg. That's vasculitis. So what is the pathology that connects all of that together? I'm glad you asked. And the obvious answer is immune complexes. So I could put IC or I could put CIC for circulating immune complexes. And I do talk about that in the book. I don't know if I've marked that particular page. Maybe I did. We'll just look at a few pages here. Because I do have a diagram of immune complex disease in the book. I just don't know if I marked it right now. I'm willing to guess. I'm guessing it's in chapter 1. I am in chapter 1. Yeah, so here it is. Well, that was good. So the diagram is on page 84. And so we're talking about parvovirus B19, arthritis, and vasculitis, and it's mediated by immune complexes, as you can see here in the book. So immune complexes are long chains of antibodies and antigens, antibodies and antigens, antibodies and antigens, and this becomes a huge monkey wrench that has no place to go. Your body has a hard time dealing with immune complexes because they are long chains, as I said, of antibodies and antigens. Well, if you have a long chain protein circulating in your blood and it's got nowhere to go, where do you think it's going to go? It's going to get stuck in the vascular endothelium, and when it creates an inflammatory response in the vascular wall, we call that vasculitis. Some of those proteins are going to get trapped in the joints, and we call that arthritis, immune complex mediated arthritis. Some of those immune complexes are going to get stuck in the lungs, and we call that immune complex mediated alveolitis or pneumonitis. And if some of those proteins get stuck in the kidneys, we call that nephritis. So we've now gone from antigen in the form of this virus to an antibody response, usually IgM or IgG. We get these long chains of connected antigens and antibodies. Those kind of are floating around in the blood, and they get stuck in different places. They get stuck in the arteries, we call that vasculitis. They get stuck in the kidneys, we call that nephritis. And they get stuck in the joints, and we call that arthritis. Those are the classic locations for this, but also of other immune complex mediated diseases. So that is the pathogenesis. That explains the connection. So from one pathogenic molecule, now you understand the vasculitis and the arthritis. Because like I said, those proteins get pushed into the joint space, but they can't really escape very easily because the entry pressure is greater than the exit pressure. So the proteins get stuck within the joint, cause a localized inflammatory response. It looks like arthritis. It's just a temporary problem typically. And that's it. That's all I'm going to say about it right now. How would you diagnose this? You're probably not going to make the diagnosis clinically because the differential diagnosis is gigantic. And you don't want to miss another condition just because you think it's this. So you're not going to know for sure on day one what this is, unless a close contact already received a confirmatory diagnosis. So if they say, hey, my kid